I think what you'll pick up from this final lecture of the morning, and probably a recurring theme with both Ryan and my presentations, there's a lot of hope and a lot of optimism, and a lot of patients who really want things that are better or different. And I think we will have those. The question is when. And I think at this point, we're still working out some of the details of what will be the next breakthrough, or at least incremental advance in our ability to treat patients with erectile dysfunction. So moving back into the pharmacotherapy zone here, I want to talk a little bit about what we do now pharmacotherapy-wise, or what we are doing and how successful it's been, but also what the potential for future interventions could be. Again, disclosures right there. Loading objectives, understand a little bit about what's limiting about our currently available oral pharmacotherapies, talk about ways we could maybe do better in terms of PDE5, and then also some novel molecular targets that may be of utility, again, in the future after some more clinical research has occurred. So we can all agree that 1998 was a seminal year in sexual medicine. With the release of PDE5 inhibitors, a revolution occurred, and things changed quite dramatically in terms of how we address this, and cultural changes kind of followed that as well. This was a big deal. The problem is, even though PDE5 inhibitors are wonderful drugs and work quite well, they're not the silver bullet. They don't solve every problem. One example of this is that patients with particularly severe ED phenotypes, that is to say post-radical prostatectomy, severe diabetes, combinations of the above, they tend not to respond quite as well to PDE5 inhibitors. Aside from patients who don't necessarily respond entirely well, there are situations where patients maybe get a good erection response but are troubled by terrible side effects. Again, these can be issues that make the use of these drugs prohibitive due to cross-reactivity with other PDE isoforms, or if the patient happens to be taking a nitrate-containing medication. There's also issues of treatment preference. Certain patients really don't want to take pills, or they don't want to take the kind of pills we have available right now. They want something different. And those treatment considerations are obviously highly relevant to patient satisfaction. So we can think about what patients actually do want. Well, is a fast onset of action good? Some would argue yes, it'd be nice if the pill came on board fast and worked fast, but is that good or bad for spontaneity? Erections are a bit different, and there are patients who are bothered by the medical nature of this. They'd rather take something well in advance or divorce the use of the medication from the actual sexual encounter. So fast onset, not necessarily the way to go for every single patient. The question about durable response, taking a drug well in advance maybe separates out the interaction between the drug and the sexual encounter. Good for spontaneity, but maybe not so great for side effects. If you have side effects that last for a day, 2 days, 3 days afterwards, is it worth it? And is that necessarily what patients are looking for? The question about can it do additional things? We don't really have drugs right now that are shown in the erectile dysfunction space to do multiple things, at least not primarily or directly. But are you running the risk, if you had a drug that could do multiple things, at causing adjunctive side effects? And is that necessarily where you want to go with this? So ultimately, the conclusion of this is that there will not probably be any one single treatment, single medication, single injection, single shockwave, single anything that's going to solve the problem for every single ED patient due to medical factors, psychological factors, interpersonal factors, and therefore a variety of treatments, having options available to offer to patients is really probably what's going to serve us best in the long term. So this is a simplified diagram, still relatively complex, but simplified in terms of how vasodilation and erections actually work. But I wanted to start with this, excuse me, just to give some context about how things work right now. Nitric oxide activates guanylyl cyclase, which activates G proteins and cyclic GMP. PDE5 is the enzyme that breaks down cyclic GMP and renders it inactive, and therefore PDE5 inhibitors are really the mainstay of therapy right now. As you can see, there's a lot of other pathways that potentially intervene upon this and different things we can do to help, but really PDE5 is sort of where the game is right now. And there are some potential options that can be considered for how we manipulate or inhibit PDE5 in clinical context. So let's do a little bit more basic science here, talking about what is PDE5. It's one of a family of phosphodiesterase enzymes that are found throughout the body. All of these enzymes either break down cyclic GMP and or cyclic AMP. PDE5 is localized largely to the penis and is selective for cyclic GMP only. It consists of 3 domains, a N-terminal fold, which is a regulatory region, a linker region, and then the catalytic area, the part that does the work of breaking down cyclic GMP. Zooming in a little bit more on this L-terminal helix, we'll get to what's called the active site, where the action actually happens and where cyclic GMP attaches in vivo. You can see here a diagram that is cyclic GMP in the middle right here. And there are 4 domains, 4 particular areas of this catalytic domain that are relevant to biology here. There's the core pocket, which is responsible for most of where cyclic GMP binds in, and then a number of other adjacent regions, a hydrophobic area, a metal binding site, and doesn't project terribly well, but a lid region here. So you'll see that there are multiple areas within the enzyme that are potentially relevant and may be relevant to how an individual molecule can articulate itself in there, how tightly it would bind, how active it might be in vivo. So moving in even closer now, looking at specifically the core pocket, kind of where the action is primarily at. It consists of a number of domains, a conserved glutamine residue, which is present across all different phosphodiesterase isoforms, and renders this one cyclic GMP specific, so that one right there. And then 2 deep pockets, hydrophobic areas of the enzyme that are responsible for, again, kind of sandwiching cyclic GMP in place, excuse me, and rendering it kind of fixed in place so that it can be hydrolyzed. So these different aspects, again, not necessarily directly clinically relevant when you're talking to the patient, but they have potential large relevance to actual drug design and finding a drug that is actually going to articulate itself best into that area. Here we have a diagram of cyclic GMP, again, the molecule of the moment in terms of erection function. And this highlighted area right here, with the red circle, is the part that binds to that catalytic domain of the core pocket. You can see the corresponding areas of various PDE5 inhibitor molecules up here, sildenafil, vardenafil, tadalafil, 2 other PDE5 inhibitors not commercially available in this country, but available in other countries down below. And you can see that this is the particular region of these enzymes or these molecules that binds to PDE5 and can inactivate it. So with the knowledge of those PDE5 inhibitors that we have, can better ones exist? Are there better ways to do this? Well, potentially yes, because we're asking the question. This is not a kind of drug you would want, but here we have 2 drugs, sildenafil, vardenafil, side by side. You can make a very subtle shift and make a difference. So here we have the inhibitory concentration for these different drugs in vivo. That is to say, what concentration is necessary to inhibit PDE5 at 50% efficacy. If you make a very subtle switch here, extend the methyl group, add a methyl group to sildenafil, subtract a methyl group from vardenafil, you get a marked difference in efficacy in terms of the potency and the concentration necessary to yield a clinical response. Now, obviously, in this case, what this graph is telling us is that sildenafil inhibits with this efficiency, methylsildenafil is less so. You wouldn't want that in a drug. But I think the point of this is not so much to say, here's a new drug we can potentially give to patients, but rather to say very subtle changes in a molecule can lead to very dramatic ramifications in how it works in vivo and what it might do to patients. Some other modifications that could be considered, and this was from a very interesting paper, a little bit older now, but it lays out some really interesting notions of how you might change how a PDE5 works. Here we have greater selectivity, so again, less likely to cross-react with other PDE enzymes and potentially be less side effect prone, an example of that right here. A longer half-life, again, deuteration, adding deuterium instead of hydrogen atoms and the ends of some of these carbon bonds. Probably not terribly financially efficacious, but interesting from a clinical, from a research standpoint. And also fluorination in terms of how well it binds and whether or not it could be potentially more effective in vivo. And the question of active metabolites. Certainly these drugs are metabolized in vivo. They turn into different things. And is it possible that some of those metabolites might themselves be active at inhibition of cyclic GMP, or inhibitive PDE5, and therefore be potentially useful? We don't really have any of those in this paper, but it's of interest. Another example here, I gave the example of how methylsildenafil, probably not a great drug, but if you start with, again, an approved PDE5 inhibitor used widely, taking this drug, making a few subtle modifications, deletion of a phenyl ring, addition of a methyl group here, and then altering the chiral attachments of these side arms, you do find a drug that leads to a substantially different inhibitory concentration, so a stronger inhibition of PDE5 and more selective, meaning less cross-reactivity with PDE11, which is the isoform responsible for some of the visual side effects we see in some other kinds of PDE5 inhibitors. So the question also, we have a drug that can work on phosphodiesterase type 5. Can it work on other things? Could it penetrate into the CNS? Is that a good thing or a bad thing? I'll leave that question as unanswered for this particular talk. But a molecule that can penetrate the CNS might be relevant here. D4 agonism, we know that dopamine is relevant to a lot of aspects of sexual function, so can it activate dopamine, potentially have roles to play in terms of sexual response and libido? Again, theoretically, maybe. Antioxidant properties, antihypertensive properties, which, as you recall, was originally one of the things that PDE5 inhibitors were investigated. Can they have cardiovascular effects of benefit? In this case, potentially. And then a very interesting idea, again, would this actually work in vivo? I'm a little bit concerned, but a nitrated version of sildenafil has been shown to increase the efficacy of cavernous nerve strip relaxation. Now, we all know about the contraindications of using nitrates and sildenafil together, or any PDE5 inhibitor for that matter. So you probably wouldn't want to give this to a patient, but again, as a principle, as something that might at least show you how you can optimize what we have already, it is of interest. So setting aside all of these drugs, which are focused again on the catalytic domain, the central part of what PDE5 inhibitors are designed to block, there is this whole other part of the molecule, the regulatory region, the N-terminal region of the protein, that actually has a regulatory role to play. You know, with cyclic GMP binding, it tends to be activated, which leads to inhibition of the enzyme. So it has a self-regulating mechanism. The question is, can we capitalize on that? If we were to inhibit this, would it actually decrease PDE5 activity and thereby build up the concentration of cyclic GMP and lead to better erection response? Again, theoretically, and there is a drug that's been shown to do that, and whether it will reach clinical application or not is a different question. So, moving outside the realm of PDE5, which is of course our target of choice for most ED management, there are other molecules that are in different stages of development, have been investigated as potential ways to ameliorate ED in patients, and we'll go over a few of these in following slides, some that are further along than others. So nitric oxide, again, you find a fair number of patients coming in asking about this. You know, they read Google, they go to WebMD, they have a knowledge that nitric oxide is part of what generates erection response, and therefore they ask, well, what if I take a nitric oxide supplement or a nitric oxide precursor such as arginine or citrulline? Certainly a good reason to believe that would be effective. The problem is that it's such a short half-life molecule, it's hard to get a nitrate donor to where you want it to be, and the precursors, the amino acids that are broken down into nitric oxide, are also not necessarily going to be absorbed and go where you want them to go. Some data along these lines, a study out of 2013 looking at an oral dosing of a nitric oxide donor and AMP on demand, looking at the baseline erectile function. This actually did reach statistical significance, but I would argue that the clinical difference of, again, a 2-point change in IIEF, not terribly robust and probably not going to do a whole lot of good for patients in clinical practice. Similar data here looking at a topical NO donor, a larger study, better design, better trial design, looking at men with mild to mild moderate ED, found that there was an improvement in erectile function in men who were treated with this nitric oxide donor, but it was only barely better than what you found in placebo. And the benefits were, again, on the milder side of the spectrum. So again, not a treatment that's going to salvage your severe ED patients. And generally, if you look at the numbers, not terribly effective across the board. So not terribly exciting or interesting for further development at this point, at least. Where there is some more potential benefit, or potential interest at least, is soluble guanylate cyclase. As you recall, nitric oxide works by activation of guanylate cyclase, which cleaves GTP to cyclic GMP. That's one of the main effects that gets erections going. And this is an enzyme that's been a lot of interest in seeing if we can modulate this, potentially because by doing so, we bypass nitric oxide. There are different versions of this, one that actually does still require nitric oxide activity to work. But if you look at the class of drugs known as cyclic guanylate cyclase activators, you will find that these actually do not need nitric oxide for activation. And therefore, there's a certain appeal to that, because if you look at the man who has neuropathic ED related to severe diabetes or cavernous nerve injury, this is a situation where you might be able to directly activate guanylate cyclase and bypass the need for nitric oxide. This might be very useful for those patients with neurogenic ED. So here we have a single study, and there's others, of course, but this is one that I picked out to highlight, looking at this soluble guanylate cyclase stimulator. This is a rodent study, so not talking about clinical studies in humans here, but looking at this versus L-NAME, which is a nitric oxide inhibitor. So basically in these animals, they inhibited the action of nitric oxide and treated some of them with this drug and some of them did with placebo. What they found is that some of the inhibitory effects of L-NAME, inhibition of nitric oxide, were ameliorated by this, so that the animals that were treated with BAY 412272 had less reductions in response to electrical field stimulation, so the muscles relaxed more easily or more so. And also they tended to contract less when treated with phenylephrine. So evidence here, again, from in vitro studies suggesting that you will find benefit from this in terms of erection response. There is a lot of interest in this, again, not just from the ED side, but also from pulmonary hypertension literature. So I think we're going to see more development along these lines, certainly for that indication, and maybe we can benefit from that as well going forward. The RhoA ROC pathway is also another topic that used to cause me endless confusion and still causes some based on how it works. But you can think of it as a calcium sensitization pathway. As you recall, muscular contraction is driven by calcium ions. The RhoA ROC pathway is designed as a calcium sensitization pathway that basically makes calcium more effective in terms of promoting muscular contraction. This is relevant in erectile physiology and vasodilation, and we find that inhibition of the RhoA ROC pathway can actually enhance erection function. So RhoA ROC inhibitors are a topic of interest, and we have one right here, Y27632, looking at a study, again, in vitro from human corporal samples this time, however, in men undergoing inflatable penile prosthesis placement versus men who were undergoing a TURP, and they had a penile biopsy as part of this research protocol. When comparing the use of this drug versus a non-specific kinase inhibitor and also placebo, you see on the graph here a reduction or a greater, with increasing concentrations of drug, a greater relaxation of the smooth muscle strip. So again, a notion here that this potentiates relaxation in response to electrical field stimulation. And a notion that this might, again, be a useful adjunct, either as monotherapy or potentially as a way to kind of stimulate a synergistic effect with PDE5 inhibitors. This is not an oral pharmacotherapy by any stretch, and it's got that funny name that the grad students who discovered it gave us, which is probably why you shouldn't have grad students name things, but here we are, it's Sonic Hedgehog. It's a molecule that has a lot to do with differentiation and growth and development, but it is expressed in human adult tissues as well. And it's thought to have a very seminal role, and Carol Podlasek from Northwestern and her team have been really instrumental at advancing knowledge of this particular protein and how it's relevant to erectile physiology. Several potential benefits with respect to smooth muscle action, and also with respect to nerve tissue integrity, Schwann cell differentiation, et cetera, and a role potentially in regeneration. So potentially something that would be quite useful, again, in our patients who've had a severe injury to both the nerves that then sets up tissue changes in the penis, something that could be of great interest. There are a number of studies that have been published by her group, and again, one that's relatively recent looking at these hydrogels. Again, in our cavernous nerve injured rat model, interspacing a Sonic Hedgehog protein incorporated hydrogel in the space of the cavernous nerve was shown to lead to improved Sonic Hedgehog expression and actually more normal histology. So basically things looked better under the microscope and the tissues were less prone to have apoptosis. So again, potentially something that could be useful for our post-radical prostatectomy patient population. So in summary, you know, PDE5 is really crucial, and I think that we'll always have that as our mainstay, as the main thing we'll want to offer to patients, and that has potential to benefit them for clinical care. That said, there are limitations to the drugs we currently have available, and there are ways you could potentially modify the molecule to make it better. Now, I say that with acknowledgement that there are a lot of factors in play here. You know, we're talking about financial considerations, pharmacokinetics, cross-reactivity, et cetera. And therefore, even if something is better in vitro or better in a computer simulation and maybe is a better inhibitor, does that necessarily mean that it is going to be developed or will become available in the future? Again, that's not certainly a guarantee. There are so many factors at play. There are a number of other molecules that we're investigating, and I think that we do have the potential that hopefully at some point, at least some of these, will become clinically available and augment our ability to treat patients medically for ED without the need to progress to other therapies. But obviously it's going to take an armamentarium, and having that variety of options available I think is going to be best for our patients. With that, I thank you all for staying till the very end, and thank you for your attention.